Hello, everyone, and thanks for joining us on this virtual discussion about COVID-19 and hematologic malignancies. Today, we have in our panel myself. My name is Tapan Kadia. I'm currently faculty in the Department of Leukemia at MD Anderson Cancer Center in Houston. And I'll let the rest of the panelists introduce themselves. We have Meredith Cowden and Dr. Shadman from Fred Hutch. Meredith, you want to tell us about yourself?
Yeah. Hi. Thank you for having me. My name is Meredith Cowden. I'm a transplant survivor. I had AML back in 2001, and then I had a bone marrow transplant. And then after that, I developed chronic graft versus host disease, which I still have. So that's some of the stuff that I'm dealing with. And I work as a psychotherapist in a private practice.
Great, thanks, Meredith. And then Dr. Shadman?
Hi, my name is Mazyar Shadman. I'm one of the lymphoma and chronic lymphocytic leukemia physicians at the Fred Hutch, and also working with the immunotherapy group and CAR T-cell therapy. It's a pleasure to be here today.
Thank you so much. Thanks for both of you for joining us and being on this panel. You know, I think the purpose of this panel is to kind of look at our practices and our patients in a slightly different light during this COVID-19 pandemic. Our practices have completely changed. Whereas previously we used to see our patients frequently and encourage them to come see us whenever possible, and have not only the patients but also their families visit us at a time when they have difficult issues with their hematologic malignancies. These days, because of the pandemic and because of the restrictions and precautions that are in place, we now only have limited visits, and so we're not seeing our patients as frequently enough. We're using video visits, and on top of that, many of our patients who come to see us in the hospital or in the clinic are without their major support system, their families, their friends, their spouses. And so that's been sort of a big stress on these patients. I think the other kind of twist with hematologic malignancies, at least the ones that we deal with, is that they often require acute care and acute management. It's not something that you can wait for or potentially push off. And these guys need acute and urgent therapy. And so I think those have been the challenges that we've all faced. I'm happy to share my stories in a little bit, but I'd like to hear from everyone to get a bit of a sense of what they're feeling. I think we're going to break this up into talking about not only COVID-19, but some of the advances that have happened in each of our fields. I'll go over myeloid leukemias. I think Dr. Shadman will cover lymphoid malignancies. And then Meredith can give us a sort of a perspective on just what it is to be a patient and go through all of this. And so I'll open up to either of you to kind of weigh in here.
Okay, so I think as far as just the past year, right, and COVID-19 and all of that, I think that it's been particularly challenging as a patient, and with all of the uncertainty as far as not knowing exactly what's happening with the coronavirus itself, but also then how that impacts the care that you're going to receive as a patient and what that looks like. And so, I think that, currently my experience is a bit different from like the acute stage, because I'm not in that anymore. I have more long-term chronic issues, but it's still necessary for me to go see my doctor regularly, especially I'm currently in a clinical trial with Jakafi. And so I have to get the medication from the hospital, and I have to be seen. And so, it's an interesting experience to go into the hospital and to see all of the different ways that they're taking precautions and ways to help protect their patients as well as themselves, but then also just within the context of the larger issue itself. And I think that there's certainly an increase in anxiety around it. There's an increase in, some kind of depression, as well as, just kind of not knowing. And I think that just from my own perspective, but also from, in working with the patients who I've worked with in my own practice, they're not specifically related to illness or cancer or anything like that. There are some, but not all. That is one of the larger themes that has been, across the board is this sense of uncertainty, fear, anxiety, and isolation. And I think that, having, being in a place where, especially with the inpatient treatment that happens, being there and going through that without your family around you, without your spouse around you, friends, whatever kind of support system you have, it makes it that much more isolating and that much more difficult. You certainly have the support of the doctors, the nurses, and the technicians, but it feels very different. And so I think that has probably been one of the most impactful things and one of the most anxiety provoking things, not only for the patients, but then also for their caregivers or their family members who are either waiting outside or they couldn't, be there, or maybe one could be in the room, and so I think that certainly is definitely a large issue, and very challenging for a lot of people. And I think that too, it makes me wonder about like how that is for you, right? Like how that is for the clinicians and the doctors and nurses and people providing the care, because it's I imagine stressful in and of itself, but then adding on top of that all of these other steps that you have to take to, make sure that the patients are okay and their families are okay, but also then make sure that you're okay and that you're, safe and have all the precautions and stuff that you need in place. So I think, there are so many different complex things to think about with this. And now I'm just kind of rambling, so I'm going to stop talking about.
No, I think this is Meredith. I think this is great. These are exactly the points that I have from the clinician side. It says I've seen just what you said, the tremendous isolation that patients feel when they're in the hospital at a time where their lives are being turned upside down, whether they be going through the disease or complication of the treatment. They're alone, and not only is it tremendously painful for them, but as you pointed out very aptly, it's tremendously painful for the family outside. And we've got into a lot of discussions about with their families, like, please let me in. I wish I could. I just, the policy won't let me. Dr. Shadman, have you experienced something along the lines? And what is your thoughts?
Yeah, no, first of all, thank you, Meredith, for sharing your perspectives. It's always, of course, we do talk to our patients, and, we do, we are aware of some of the limitations and some of the challenges that they have and they've had in the past few months. But it's always good to, as somebody who's gone through different types of therapy, as you mentioned, it's acute phase, and then later dealing with the complications. And that's exactly, as a lymphoma physician, I can tell you, dealing with wide range of diseases as a lymphoma oncologist. We do treat patients with low-grade lymphomas. We do treat patients with high-grade lymphomas, and these days we use CAR T-cell therapy or stem cell transplant for treating these patients. So you have a very diverse group of patients, some with acute need, and you can't delay their treatment or their care, no matter how bad the pandemic is and how active the situation is, and now no matter how busy the ICU or critical care colleagues are, you have to treat somebody with active lymphoma. And on the other hand, you have patients with more indolent type of a disease, as far as you know, and some of these patients we follow every 3 to 6 months, of course, assuming that their disease is still slow growing or indolent. And so we had to come up with different strategies tailored to different type of patients we were dealing with, which was in a way very challenging. You have to kind of step back and look at your patient panel. And our group, for example, very quickly came up with guidelines, as all major institutions, and we decided to utilize the virtual platform for a lot of those visits. We were able to use a lot of, as you know, for a lot of academic centers, we get patients who come from 2, 3, 4 hours away, and we try to utilize local resources, like sending them to a local lab and working with them on a virtual platform, and sometimes delaying their visits. Sometimes in some of the patients who were on active treatment with low-grade disease, we were able to skip some of their treatments, especially infusional treatments, or if you had somebody on chemotherapy with who could have a pause. We did that, but at the same time, we had to be very careful. It's not just the direct complications from COVID. For cancer patients, it's also important for them not to miss the opportunity of cure if they have a curable disease, or if they have a disease that's out of control. You need to make sure that they get the right treatment. Unfortunately, we did see, and we do hear about patients who, at the peak of the pandemic, did not receive the type of treatment they should have received, and that's one of the things that the field is really interested in terms of looking at the maybe indirect complications or consequences of the COVID-19, which basically is lack of or not receiving the appropriate care for cancer patients. So, what the other factor that makes it challenging is the fact that this is a very fluid and very dynamic situation. I can tell you in Seattle, for example, we're back to normal practice now for months, but this can easily change in the upcoming weeks or months, as you know. So you have to have that flexibility of kind of going back and forth between in-person versus virtual, using your clinical nurses, some of them working from home and things like that. So I think we've learned a lot from this situation. I hope we don't have to use it again, but this is something that I don't think we have experienced anything similar to this in our field, and yeah, just looking forward to going back and staying back to the normal practice, but we don't know about the future.
Yeah, that's fantastic. I think you bring up some excellent points, Dr. Shadman. I think that, since we all deal with hematologic malignancies on a regular basis, and these are a little bit different than some of the more chronic diseases, it is imperative that we do see our patients urgently and start treatment actively without waiting, despite them having restrictions in place from the COVID pandemic. And I think it's important to recognize that people should be followed regularly and carefully. And we've certainly implemented, like you said, some virtual visits when we can. And I'd love to get back to normal. But I think that also as we go to the next phase of our treatment in medicine, that many of these patients who we can follow a little bit long distance, whether it be surveillance or chronic follow-up, maybe we'll start incorporating the virtual visits into our own practice, even if and when the pandemic is over. So I think that certainly, I think we definitely will evolve. It's important to see our patients regularly and see them acutely. Now, before we get too far away from heme malignancies, I think it's important to get back into, why we are doing this sort of year-end review of what are the new advances. And so, although COVID has been sort of the major headline in most of our lives and our practices, I think it's important to recognize that we've also made significant advances in the treatment of our diseases based on tremendous research and hard work from many folks around the world and around the country. And so what I'm going to try to do is, I just have one slide. I don't want to inundate you folks with too many slides. I'm sure you've seen already many, but I have one slide which I wanted to share, which kind of summarizes the recent FDA approvals in acute myeloid leukemia. That's the disease that I treat most frequently. And let me just, since we're going to talk about advances, I think that's, like I said, important to talk about some of the new agents that have been approved in AML. And so for many of you who have treated AML or know about AML, there has not been a new approval in AML in several decades until just about 3 to 5 years ago, when we started seeing, a rash of approvals one after another, based primarily on the hard work with clinical trials, but also biology that better understands the underlying underpinnings and pathophysiology of AML. We've been able to leverage next generation molecular sequencing, which looks at mutation analysis to identify that AML is actually a very heterogeneous disease. That although in the past we all treated all AML as one with 7+3, which is Ara-C and an anthracycline, we realize now that that probably wasn't the most optimal approach. I think we probably knew that then, but we didn't know how to identify the different subgroups. And now with the use and availability of these next generation sequencing technologies, we're able to really identify different subsets of disease and then understand the biology of each of those subsets and develop treatments that are specifically individualized and targeted to those subsets. And And certainly the efficacy has improved in each specific subset based on using these new drugs. Now we need to convert that efficacy into overall survival. And so I'm going to go through this slide briefly. And as I go through it, I'm going to give you a little bit of a flavor of how we've implemented these drugs along with our standard treatment in the era of COVID. And just as an overview before I start, I think like Dr. Shadman pointed out, we have moved many of our visits to virtual visits, and these are visits that are that don't require in-person physical exam or don't require a blood or platelet transfusion, for example, which many of our patients do. And so those have moved to video visits, and they can be even flexible. They can be late in the day, early in the day when normal clinic hours are not in session, where you can monitor and go over patients and the side effects that they're having with different treatments. Many of the drugs now in AML have become orally available drugs and things you can get in the pharmacy, which patients are self-administering. So on this list, things like Mitostoron, Venetoclax, Enasidenib, Ivosidenib, Gilteritinib, and most recently CC486 are all oral drugs. These are drugs that I can give a bottle of pills to the patient and say, take this home, take it, I tell you. So we use video visits quite frequently now, both myself, but also my mid-level provider, to kind of check in on the patient for A, side effects. Hey, how are you doing with this? Are you having any side effects? This is how I would deal with that. This is how I would take the drug. And B, compliance, right? Are you taking the drug? Hey, did you remember to take this drug? Did you forget? Because as we know, with many of these oral targeted agents, compliance is certainly important. And now that it's oral, we really have to lean on the patients to make sure they're compliant in these life-threatening diseases. The next thing that we've done differently is, as I mentioned in AML patients, the issue with blood transfusion. So these patients come in frequently for blood product transfusions of either blood or platelets. And so when they come in for blood draw, we have actually implemented specific spacing in our waiting rooms, 4 to 6 feet apart, so that patients are not close to each other. Everyone obviously has to wear a mask. Same thing in the treatment centers. They're in their isolated individual pods so that they are away from each other, potentially reducing the risk of transmission. In terms of hospital visitation, in patients who are frail or have problems with dementia, who are not able to take care of themselves, we will allow one family member, but it's extremely strict on who will be allowed. And so that's how we're doing family visitation. Obviously, if there is a situation where the patient is very ill or there's an end of life issue, we are certainly allowing one family member to be at the bedside with the patient. But that family member must stay with the patient and is not allowed to leave for the duration of the hospitalization. And if they do leave, they're not allowed back in. And this is to prevent sort of back and forth transmission from the community into the hospital environment, which is sort of a clean environment. So that's sort of a general overview of some of the practices that we've been doing for COVID-19 as it relates to acute myeloid leukemia treatment. Now, let me go over just briefly what the advances are, and many of these have been around for a few years now, but some of the later ones are brand new. I'll also mention some of the clinical trials that are in progress and some of the presentations both at ASH and ASCO, which have been already presented or will maybe coming. So the first is Mitostoron, which is a multi-kinase FLT3 inhibitor. This is approved as the RATIFY trial in combination with 7+3, cytarabine and daunorubicin, in induction and then in consolidation. And this showed for the first time an improvement in overall survival in combination with chemotherapy for patients with FLT3 mutated AML. So finally, improvement in survival over 7+3 alone. And so now FLT3 inhibitors are incorporated as standard in the front line for newly diagnosed patients with FLT3 mutated AML. This is a drug that definitely improves overall survival. Now, we are starting to build on that. We're using next generation FLT3 inhibitors like Gilteritinib, as you see in clinical trials, also in the front line. Another investigational drug called Quizartinib, which is not approved, is also being studied in the front line. We're also studying Mitostoron in a maintenance setting. That is to say, in patients who have achieved a remission, who have had a stem cell transplant, we're considering Mitostoron after transplant as a maintenance strategy. So that's ongoing. Gemtuzumab ozogamicin, or Mylotarg, as you may have known, this drug has been around for a while, was taken off the market and now reapproved. It is a antibody drug conjugate against CD33, which when combined with chemotherapy or even as a single agent has shown significant benefit in a subset of patients. So mostly those who have favorable acute myeloid leukemia, those with core binding factor, and we're using that primarily in those patient populations. CPX351, also recently approved just a couple years ago, is a liposomal formulation of 7+3, which has shown significant benefit in those patients with secondary AML. So those patients with MDS-related changes, as well as those with therapy-related AML. You'll see at ASH some presentations of CPX-351 potentially. I know they've been submitted, such as combinations with various drugs, including Mylotarg, as well as with Venetoclax, and potentially even lower doses of CPX-351 have been studied. So I think it's a drug that may have other uses and implementations beyond its current labeled indication, but those are still under investigation. Galastagib is the first hedgehog inhibitor, which presumably affects the stem cells of AML, and in combination with lotocytarabine showed improvement in outcomes over lotocytarabine. And I think the next one, probably the biggest revolution in AML recently has been the implementation, the approval of Venetoclax, which is a BCL2 inhibitor, which I'm sure Dr. Shadman knows well about and we'll talk about in CLL, but it is a drug when combined with low intensity therapy has significantly improved complete remission rates from around 20% all the way up to 50, 60%, with a median overall survival in the range of 14 to 17 months, up from around 8 to 10 months. So significant improvement, and has changed the standard of care for older patients and unfit patients with newly diagnosed AML. This is now the standard. Now, because it is such an active drug in combination with therapy, we and others are also testing in combination with more intensive therapy. Now, Venetoclax, when combined with these drugs, does give you a good deal of myelosuppression, which in the setting of infectious disease, including COVID-19, one has to be very careful, have close follow-up, and have constant PPE, which we recommend in our patients. And so something to keep in mind. But Venetoclax is being studied in other combinations as well to see if there's other approval strategies. Finally, the next two are IDH inhibitors, enasidenib, ivosidenib, oral drugs, single agents approved in the relapsed refractory setting in patients with IDH2 or IDH1 mutations, respectively. Again, these are oral drugs, and so we can give these drugs to the patient and monitor them virtually by virtual visit during COVID-19. But there are certain things and syndromes that we really want to make sure that the patient is well educated on. Primary among those are differentiation syndrome, which can present subtle as a minor elevation in creatinine, a rash, shortness of breath, an elevated white count, which again cannot be checked unless the patient comes in for a blood test. But so these are the kind of the borderline patients where they're doing well on their drug, but we want to make sure that we have constant follow-up with them to make sure that they're not having any side effects, which can be potentially life-threatening. So although we give these patients IDH inhibitors and let them go home, we do maintain close follow-up and like them to get blood tests throughout their initial treatment on this. But again, response rates about 40% in the relapsed and refractory setting with a single agent oral medication, which is kind of a tremendous advance in the field. Gilteritinib, a FLT3 inhibitor, again, that is approved in the relapsed and refractory setting as a single agent. Again, these people, although they're getting just an oral medication, need to be followed closely and do come in for blood count checks, examination of their chemistries to make sure their liver enzymes aren't elevated, and potentially requirement for transfusions, as well as detecting relapses, which is often done by blood work, as well as bone marrow aspirations, biopsies, which again require a visit in the hospital. And finally, the most recent drug, I think, oral azacitidine as a maintenance strategy, the first maintenance strategy approved in acute myeloid leukemia, a low dose oral azacitidine that is absorbed at a lower rate than the parenteral version. It can be given as an outpatient. In fact, I have several maintenance patients which I am monitoring, maybe not with oral azacitidine, but low dose parenteral azacitidine, which I monitor by video visit because they may live 4 to 6 hours away or a different state across the country, and they may not be wanting to travel by plane or otherwise. And so we are monitoring them video visits, and they see their local doctors for blood work. So just a kind of a really quick run through of the advances in AML, some of the places we're going with new clinical trials, and some of the challenges that we're trying to deal with in a very difficult disease in the setting of a pandemic. So I'll stop there, and if anyone has any comments, or if Dr. Shadman wants to take over and discuss some of the lymphoid, I'm happy to go there. And Meredith, if you have any questions or concerns about what I've said before he gets in there, I'm happy to take your questions.
No, I don't think so. I mean, I think I think that all sounds great, honestly. You know, because when I, like, you know, before I got my transplant and whatnot, like I forget what the chemotherapy I had was, but, you know, it was the IV. There wasn't any possibility of an oral medication, you know, treatment, which I think is pretty amazing, especially now. And especially given just the fact that you were saying, you know, a lot of people potentially live further away from their treatment centers. And so this gives an opportunity for them to have a bit more of a normal life, you know, and just take the medication, take the pill, and then, you know, I'm sure that, you know, like you were talking about, there are some side effects and stuff, but I think that's great. Yeah. Okay.
Very nice.
Mm.
Mazyar?
Okay, great. So I also have 2 slides, and what I'm doing, I'm using CLL as an example of a disease that we really try to come up with some kind of guidelines or recommendations early after. Can you see my screen in the
Yes.
presentation mode? Okay.
Yes, great.
So really, my goal is not to go through the details of these guidelines, but really, it was a great example of how CLL community came together from the early days of the pandemic. And you see that there were multiple publications, initially in form of recommendations and guidelines in the absence of any data. Of course, CLL physicians kind of came together and came up with some recommendations. And then over time, we started to have some more data from clinical studies and updated the information. And so basically, what's unique about CLL is the fact that you have many drugs in different forms, from oral targeted therapy, medications in different forms, and then you have monoclonal antibodies that are infusional, and then you have chemoimmunotherapy that in some selected patients are still a reasonable choice. So, but then you have actually a significant number of patients who are diagnosed with the disease, but they're not an active treatment. So, as you see here, we had first of all, we knew that CLL patients, for many reasons, are at a higher risk of having infections in general, and then we also assumed that if they contract the COVID-19 infection, they're more likely to have a more complicated course. And later on, both the US and European groups actually published their experience with that, and we kind of showed that it is true. If a patient with CLL, and interestingly, at least based on the US data, it didn't matter if they're on active treatment or not, they were found to have a more complicated course with higher rate of mortality, at least compared to what we see in non-cancer or non-CLL patients. So really, the idea is to show you that we have to be very specific in terms of, okay, if you have a patient who's on watch and wait, then try to avoid bringing him back to the clinic, as I mentioned. And if you can control their symptoms by measures other than starting cancer-directed therapy, do that. And then we also had some recommendations in terms of type of treatment that was recommended to be started, not based on any data or anything related to the pathophysiology of disease or the mechanism of action of the drugs, really mainly from the logistical standpoint. As Dr. Kadia mentioned, Venetoclax is one of the very important drugs for CLL. It's a great drug and very attractive for many reasons, but at the same time, in terms of at least initiation of therapy, requires multiple visits and multiple blood tests and involvement from the clinical team as well as for the patient. So, of course, if you're at the peak of the pandemic, you would rather preventing or avoiding that kind of a situation. So we had to make decisions like that in patients who had, of course, other reasonable options. And as you see there, there were specific type of treatments, including chemotherapy and monoclonal antibodies, that if a patient was diagnosed with the COVID, we definitely stopped the drug or treatment. Again, more recently, there are some uncontrolled and single-arm studies showing that maybe protein tyrosine kinase inhibitors, which again, that's another important class of medications for CLL, they may have some protective effects against the hyperinflammatory phase of the COVID-19 infection. So for that reason, it is also something that we talk about, or we suggest that if patient is otherwise, if there's no contraindication otherwise, it would be reasonable to keep a patient who's on BTK inhibitor if they get the COVID-19 infection. And we have seen actually very good responses in clinical practice. So again, really the idea is to show that how diverse this population is, and really specific patient by patient decisions need to be made. Now, in the lymphoma world, interestingly, we didn't have the luxury of having the number of drugs that the AML colleagues had, although this field, as you know, has been very productive in the past few years. But for this year, for example, after maybe 3 or 4 years of having multiple new indications for CLL, for different drugs, different generations of Bruton tyrosine kinase inhibitor like ibrutinib or acalabrutinib, but different lines of therapy, Venetoclax in different combinations in frontline or relapse, and also PI3 kinase inhibitors. In the past 11 months and during the pandemic, we haven't had a new drug or new indication for CLL therapy, which is okay, because for other lymphomas we did have few new drugs. So the most important one being CAR T-cell therapy, which is now approved for mantle cell lymphoma. This is a major achievement for the field of lymphoid malignancies. As we know, CAR T-cell therapy has been available for lymphoma now for years, mainly for diffuse large B-cell lymphoma. And until this recent indication of bruxocaptagen autoleucel, which is a CD19 targeted CAR T, and the approval came after a major study, ZUMA-2, which was led by colleagues at MD Anderson and other colleagues from around the country. And basically, the indication is for previously treated mantle cell lymphoma, and this really adds a major treatment option for our patients with mantle cell lymphoma. And the label is actually very relaxed, and basically patients after one line of therapy could be considered for this CAR T therapy. So I would say this is probably the most important achievement. We've already started using this drug as an FDA approved drug or product, a cellular therapy product. And for those of us who are less exposed to CAR T therapy, and this is kind of a process that's more similar to a stem cell transplant process, where at least for our institution, patients would come here, they would start having assessments for their disease and different type of comorbidities, and at some point we will approve them for moving forward for the treatment. And the next step is to having them going through leukapheresis and getting their T cells collected, and then the T cells will be modified in the lab. And in the meantime, they may or may not need what we call bridging therapy using treatment. And then they receive a combination of 2 chemotherapy drugs called lymphodepletion, followed by 2 days of wait, and then re-infusing their now modified T cells. And these patients, and again, practices could be slightly different, but in general, they will be observed very closely for 30 days after infusion of the T cells, and the portion of that time will be in the hospital. So it is a labor-intensive process. For patient is a lot of work. There is a need for a caregiver. This treatment needs to be offered and done in an experience center to make sure that the medical staff have enough experience taking care of the side effects and dealing with them. So I would say that's the biggest achievement that we have had in this field. Now, for follicular lymphoma, which is another type of indolent lymphoid malignancy, we have a new drug called tazemetostat. It's an EZH2 inhibitor. We know that EZH2 either mutation or overexpression is linked to different type of malignancies. And basically what EZH2 does, it inhibits some of the genes that are responsible for suppressing some tumor developments, and the drug blocks the EZH2, and that's how it works in terms of disease control. Now, it's an oral drug with a very acceptable toxicity profile. Like any other cancer drug or blood cancer drug, you do see side effects like low blood counts and some general side effects, but really there's nothing that stands out as a major concerning side effect. It's a new drug that needs to be tested, and we'll learn more about it. The approval is for patients who have the EZH2 mutation in their tumor, or if they don't, you need to basically show that there's no reasonable alternative option for this patient. And so that's a great addition to our toolbox for treating follicular lymphoma. And so I think that's important. And then we have two drugs that are recently approved for diffuse large B-cell lymphomas. You know, that's the most common high-grade lymphoma, meaning that you always need to start to have these patients on treatment. These patients can't wait. So this would be an example of the patient requiring treatment regardless of what's going on in the world from the COVID standpoint. So we do have a monoclonal antibody against CD19 that's now approved for large cell lymphoma. The drug is tafasitamab. As we know, CD20 directed monoclonal antibodies have been around. We have 3 of them approved for different type of lymphoid histologies: rituximab, ofatumumab, and obinutuzumab. So this would be the first CD19 targeted monoclonal antibody. Now, the indication is in combination with lenalidomide, which is a drug with immunomodulatory effects, and the drug has activity against different types of lymphoma. And in combination, this new combo would be a great option, or an option for some patients. The label is for patients who are not eligible. I'm sorry, they're not eligible for stem cell transplant, meaning that if you have a frail or a patient who, for whatever reason, after even the first relapse, is not considered to be eligible for autologous transplant, you can offer that patient this combination. It's an oral drug, lenalidomide plus an infusion, and it's something reasonable for even smaller cancer centers to provide to patients. So I think that's another important combo. And then lastly, we have selinexor, which is another oral drug. It blocks XPO1, which is basically a shallow-link protein that's involved in the export of the proteins from the nucleus to the cytoplasm, and it's overexpressed in large cell lymphoma. So that's how this drug works, and it's an oral drug. Now, the toxicity profile is something that we need to be aware of and think about it. GI toxicity and cytopenias could be major problems, and the response rate are not necessarily outstanding, but it could be a reasonable option in selected number of patients. So as physicians, we always like to have access to different drugs, and on a case-by-case basis, of course, you make a decision after discussing and involving the patient on how to use these drugs. Again, having another oral medication in the time of a pandemic or uncertainty is always something that we look forward to. So I think that's it for me in terms of the new drugs, and just an example for how we approach CLL during the pandemic. If there's any questions, I'm happy to answer. Otherwise, I will.
Dr. Shadman, thank you. That was really good. One of the questions I had for you is, how did you handle new CAR T cell initiations and treatment around the pandemic time? I can tell you ourselves, we put a pause on it for a little while, and it was a little frustrating. So what did you guys do?
Yeah, I think let me explain the transplant and CAR T together, if I may, because we kind of made a decision between the two groups, and we came up with a list of the type of transplants could wait. For example, like if you have somebody with multiple myeloma, and those patients some of them could wait, or like if you have somebody with mantle cell lymphoma in the first remission, that is a controversial area to begin with. So some of the indications we were able to decide that, okay, we're not pursuing those. But and same thing with CAR T. I think for our clinical trials, we did hold number of our clinical trials. Either it was a decision that we made, or some of the kind of multi-center studies. The decision came from the sponsor, so that happened. I don't think we slowed down or stopped our commercial CAR T therapies, but the number of patients definitely dropped for other reasons. And but it was a challenging time, and as you probably have the same experience, the rebound that happened after that initial that pause is something that it's. I mean, I just came off service month of October, and I'm glad that a lot of these patients were able to eventually pursue that kind of a treatment. But again, we need to learn a lot about what happened to those who, unfortunately, because of that delay, never made it to transplant or had other complications in the meantime. So,
yeah, I think you're right. I think, so for us, at least in leukemia, the majority of the ones we were looking at in terms of CAR T cells were on clinical trials. There were a couple of commercials, but those are mostly the young folk. And we did have to shut down not only those clinical trials, but many clinical trials during that time. In fact, we were only allowed to or able to keep open sort of really, really critical clinical trials during that time. And then people didn't come in. I mean, like you said, we had a tremendous drop off in the amount of patients that we saw, and many of the patients that needed the trials couldn't get on for one reason or the other. And I'm sure there was a tremendous hardship for many of these folks who couldn't get into special therapies and during that time. But we should definitely go back and look at that. But I think, as you said, there has been a snap back, and the rebound has been fierce. And so our hospital's full again, and so on. Meredith, any comments on what we've talked about in terms of the advances in lymphoid malignancies that we've seen and myeloid, and if you were a patient that wasn't able to get a clinical trial during that time, some of the thoughts and feelings you might be going through?
Yeah, well, that was one thing. So as far as with the clinical trials that couldn't go through, so was that primarily because, like, what was the basis of that? And then what was the alternative option for those patients? Like, what?
Yeah, so for us, it was a policy of sort of trying to minimize the workforce that was coming into the hospital, because for us, even now, even to this day, the majority of our research staff are not in the hospital. The way they used to be right by our sides in the clinic, they're working all virtually. I still come in now and for patient care and stuff, but so the research staff was down. The data coordinators, there's a lot of intricate parts that need to happen, which require people, and that wasn't happening. Getting drug shipped, getting people to come for clinical trials, to have multiple visits. And certain clinical trials require visits to happen exactly at a certain frequency and time. And you could do a little bit of deviation here and there, but missing doses and things, it's not conducive to a good clinical trial. And so we had to, because of that reason, much of that was shut down. Did you have the same experience, Dr. Shadman?
Yeah, so I totally agree. I mean, there are factors like when you have a sponsored study, they would like to have access to your site anytime, and some of them are not okay with virtual access. And we made a policy early on that right now at the Fred Hutch campus, there's no visitors permitted, and so we have limitations, and we still have. So yeah, and one other kind of point that I wanted to make is that when you start a treatment like CAR T therapy or stem cell transplant, there is an expectation of a percentage of patients who may require ICU. And when you are in the middle of a pandemic, and with especially what we went through early on with concerns with the ICU beds availability, and really our critical care colleagues were still overwhelmed with taking care of the COVID patients. So we had to be mindful of that. So we had to plan for a possible surge for COVID patients. So I would say that was a situation that was being monitored on a weekly basis. And if we had a signal that maybe our ICU bed availability is not going to be reasonably adequate for our expected critical patients from immunotherapy or transplant, then we would slow down. But that was another factor too. I mean, these therapies are linked to the hospital and other colleagues that help us taking care of the patients. So that's another factor.
Yeah. Okay. And just out of curiosity, as far as have you had large numbers of patients who you see for cancer treatment of, blood malignancy who contracted COVID?
For our, it wasn't a large percentage. I think it was probably around the same, or actually I would say a lower percentage than the general population. Many of the people that we treat are already, at least even before the pandemic, were wearing masks and gloves and
Right.
staying committed. So I think that continued habit kind of protected them from getting it. So we had a fewer, actually, percentage-wise, in my population who contracted COVID.
Same experience. I mean, as a transplant patient, these patients are expert in protecting themselves, and I think that helped. In heme malignancies, transplant immunotherapy, I think extremely low, if anything. So that's great.
Yeah.
But,
Yeah, it is. Well, and I know I forget who I was talking to. I was talking to some doctors, and we were talking about how well things were moving forward in terms of could the patients go ahead and get their transplant, or did they need to wait, and how was the unit running just as a whole with COVID being present. And so the guys that I was talking to, sounds like they've had similar experiences to what you two have had as well, which I think is good. And I think to your point, yeah, I mean, the patients on immunosuppressive drugs or chemotherapy or anything, you learn how to live without in protecting yourself and not engaging in activities that involve large crowds of people, or you wear the face mask and all of that. And so I think that's I think that makes a big difference too. I was just curious. Okay.
Very good. So I think I want to thank everyone. I think we've had a really good discussion looking at both lymphoid malignancies, myeloid malignancies, a patient perspective in the era of COVID. I think it's easy to look at this year kind of as a lost year in the pandemic. But I think that we've made advances in heme malignancies, and we continue to do so. I think if anything, it has strengthened our ability to adapt a little bit better, to learn new methods, whether they be virtual visits or surveillance visits over Zoom, or even these meetings. We've missed a couple of large national meetings. I think the ASH meeting is going to be completely virtual. So, things have changed a little bit. We've gotten a bit stronger, and I hope we get through this pandemic. But again, I think that we've made significant advances. And those are my final comments. If you folks have anything else, I'd be happy to let you guys speak, and then we can sign off.
Nothing for me. I hope that everybody's safe, and we don't look for another peak, but I think with the experience that we had with the prior one, hopefully we will be even more efficient and more protective for our patients.
Great, thank you.
Yeah. Well, and I think too, just to your point earlier, I think it is a wonderful insight onto how quickly the medical field and people can adapt and make big changes when they have to. And I think that as a whole, it seems to me that everyone in this field has done an excellent job with doing that. And just from as a patient, I want to say thank you just for all of the work that you do, and how quickly you figured it all out. So thank you. I appreciate it very much. And I'm sure there are many people like me who do as well. Thank you.